committee. Let me summarize the scientific work of the first candidate from the Department of Prosthodontics. Dr. Kata Kelemen was born in 1994 in Veszprém. She received her diploma from the Faculty of Dentistry at Semmelweis University in 2019 with summa cum laude. She completed her specialization and became a clinical specialist in prosthodontics in 2022. During her residency years, she had the opportunity to learn at the clinic under the supervision of Dr. Peter Schmidt. She has been teaching prosthodontics and gnatology at the Department for English, German, and Hungarian students since 2019. In 2022, her student got first prize at the Student Scientific Conference in her research topic. In 2021, she has admitted to the doctoral school at Semmelweis University, where she started her research work as a PhD student. Her research focuses on treatment possibilities of temporomandibular disorders. She gained recognition for her work on the Digital Dental Society in 2021 in Chernobyl. Her scientific examination of this topic was recognized with a poster presentation at Semmelweis University in 2022. She is involved in education at the Center for Translational Medicine, where she supervises the PhD work of 14 students. She has published results on this topic in 2 international top journals, and she has a total of 14 scientific publications in the 1 journals, which resulted in the cumulative impact factor of 44.5.
Thank you very much, Professor Hermann. So now I would ask the candidate to hold her presentation about her thesis in the limited time, please.
Thank you, Professor Hermann, dear committee, dear audience. I would like to introduce you my PhD work, which is about the treatment possibilities of temporomandibular disorders. My name is Kata Kelemen, and I'm from the Department of Prosthodontics at Semmelweis University. My vision is to treat patients with a multidisciplinary team and also to take into consideration the evidence-based literature. My mission is also to engage myself to patient care and research by conducting many clinical trials. My specific goals include the investigation of conservative and semi-conservative treatment possibilities for myogenic and arthrogenic temporomandibular disorders as well. A little bit about the TMDs background. This is the 3rd most common stomatological disorder which affects the masticatory system, including the muscles and the joints as well. And the main symptom of the disorder is the pain, and it has a very important impact of the patient's quality of life as well. The 75% of the TMD patients might have psychological problems. However, there is an unknown background and also a lack of prompt etiology of this disorder. Thus, the healthcare workers may face many obstacles in this field. There is also no universal agreement on the best treatment strategies of the temporomandibular disorders. Thus, our first aim was to conduct a systematic review and meta-analysis of randomized controlled trials in the treatment of myogenic temporomandibular disorders. The most common type of the disorder is the muscle disorder group with the percentage of 45. However, the exact origin is still debated, but most commonly it's related to vasoconstriction and the relevant arteries and the accumulation of the metabolic waste products. The aim is to restore the function and relieve the pain of these patients. Here you can see in this table the first-line treatments of the temporomandibular disorders, which include the physical therapy, occlusal splint therapy, manual therapy, education and counseling as well, and we sometimes use pharmacotherapy as well in the treatment. Even though there were some previous systematic reviews and meta-analysis in this topic, however, they had high limitations, like the high heterogeneity of the population. That's why our review's aim was to narrow the intervention and the comparator group's population and to have a more homogeneous results in this field. We followed the PRISMA checklist, and we also adhered to the Cochrane handbook as well. Our study was registered in the Prospero. There you can see the PICO framework which was followed. We included patients, adult patients with local myalgia and myofascial pain. The intervention was additional splint therapy to physiotherapy, manual exercise, education and counseling as well, while the comparator was physiotherapy, manual exercise, education and counseling. Here you can see the two outcomes that we had. The primary outcome was mainly the range of motion, which was measured in millimeter by caliper or a ruler. And our secondary was the pain perception, and also we assessed the quality of life of the patients. We conducted two kinds of meta-analysis. The first one was a self-control one, where the control and the treatment groups were compared to the baseline values. And the second one was where the treatment and the control groups were compared to each other. In this meta-analysis, we used random effects models, and the standard deviations were extracted from the data. We used forest plots to graphically summarize the results. Here you can see our systematic search, which was carried out in 4 major databases. And at the end of the search, we could use only 7 articles for the assessment. We did the quality assessment with the risk of bias and also with the grade pro. Here you can see in the last row the Kucha article, which had a high risk as the patients could take some painkillers that could highly modify the results. Here you can see our first result, which was maximum mouse opening between the baseline and the 1 month values. Only 2 articles were included. Here you can see the I-square value was quite high, and the effect size in the intervention group was 3.69, which means that the maximum mouse opening increased with 3.69 millimeter, while in the comparator group it increased with 3.62 millimeters. We also carried out this assessment in the pain perception. Here 5 articles were included. In the intervention group, the pain decreased with 2.54, and in the physiotherapy group, it decreased with 2.33. As a conclusion, we can use the conservative treatment possibilities, the first-line treatments for myogenic temporomandibular disorders. However, there was only a slight difference between the intervention and the comparator group that can question the usage of the additional splint group. And also, a multidisciplinary team can be included in the treatment of myogenic temporomandibular disorders. We also compared our results with international other articles. In the first one, they concluded that the combined therapy with manual therapy, counseling, and education resulted in better outcomes. In the second one, the active stretching and the manual mobilization resulted better outcomes than with the Michigan splint. And also in the third one, the manual therapy was superior to home exercises, as in these cases, it's highly dependent on the patient's compliance. We did a systematic review and network meta-analysis of the treatment of arthrocentesis of arthrogenic temporomandibular disorders. 90% of the patients experienced fewer symptoms with the first-line treatment. However, there are some severe cases when more invasive treatment is needed. That's why, in this case, we can use the arthrocentesis. And normally, the superior joint space is targeted. And most of the time, we are using Ringer solution, hyaluronic acid, and corticosteroids as well. However, some platelet concentrates and glucosamine show promising results. The aim of the arthrocentesis is to flush out the inflammatory chemicals, and also to remove the intra-articular adhesions as well, and to improve the disc mobility. Here you can see the mechanism in this table of the used materials, And the main indication for arthrocentesis are the dislocation of the articular disc with or without reduction, and also the joint pain and other internal derangements of the temporomandibular joint. We also followed here the PRISMA guideline and the Cochrane handbook as well. This study was also registered with the ProStero, and we followed the PICO framework. We mainly collected data from adults with temporomandibular disorders from the Wilks stage classification of 2 and 5, and the intervention and the comparator were medical devices that I have already shown you previously. And the primary outcome was the range of motion, and the secondary one was the pain assessment on a visual analog scale or on a numeric rating scale. The mean differences and the standard deviations were evaluated. We used a network plot and also a Pervasian Bayesian network meta-analysis. We used random effects models, and also we used the Sukra and the forest plots to graphically summarize our results. Despite the prior network meta-analysis was conducted in this topic, however, they not only assessed the conservative and semi-conservative treatment possibilities, but also the surgical ones as well. And our systematic review and meta-analysis aimed to summarize the treatment outcomes of the recently used intra-articular devices. Here you can see the systematic search. We have done this in 4 major databases, and 21 articles were used in the quantitative synthesis, while 18 were used in the qualitative synthesis. Here you can see our first result, which was the maximum mouse opening at 1 month. In the columns, you can see the different rankings of the different materials. Here we compared everything to the saline injection, and the saline PRP showed the best results with 4.48 millimeter increase in maximum mouse opening. While in the 12 months, the saline steroid resulted as the best treatment possibilities for arthrogenic TMD. We also assessed the secondary outcome, which was the pain perception in 1 month. Here also the saline PRP showed the best results with 2.89 decrease on the visual analog scale, and this tendency remains at the 1-year follow-up as well. As a conclusion, we can use the PRP saline combination and also the saline steroid combination as well. However, we really have to take into consideration the side effects of the steroid usage. Here you can see a short summary of the short-term and of the long-term usage of these materials. The saline PRP resulted in a clinically noticeable improvement in both the maximum mouse opening and also in the pain perception, while in long-term the saline hyaluronic acid saline steroid effectively increased the maximum mouse opening, while the saline PRP was the best in the reduction of the pain perception. We also compared it with many international articles. In the first one, for maximum mouse opening, the saline PRP were the most efficient. In the second one, they compared arthroscopy as well, and that was the best treatment possibility. While in the third one, the Salangarian one, and they concluded that the hyaluronic acid and PRP were the best. However, we should use autologous medical devices to avoid possible adverse events. Here you can see my scientific data. I published 2 D1 journals for my dissertation. I have 14 D1 articles, and the cumulative impact factor is 44.5. I also have other activities, like in 2021, I attended in Italy the Digital Dental Society, and I made this poster, while I also submitted another poster at Semmelweis Symposium in 2022. And I've been a scientific methodological supervisor here at the Center of Translational Medicine, and I have 14 students. And since 2019, I've been teaching prosthodontics and gnatology as well in 3 languages. And I would like to thank you for your kind attention with a quote from Fred DeVito: "If the plan does not first change the strategy, but never the goal."
Thank you very much for this interesting presentation of a very up-to-date topic. And now I would like to ask the opponents first if they have any questions regarding to the topic and the thesis of this Kelemen.
Thank you so much. Thank you, Kata, for a nice and very clear presentation. As you have two topics on the treatment, I would like to go one step back to the diagnosis. And we know that usually these patients have a complex profile. So I wonder if in your reviews and in your dedicated work, you looked actually if the included studies considered the bias that could be there with the diagnostic part. Because in the first one you have like the splint working or not. But is this purely a treatment level or is this also a diagnostic problem?
Thank you so much for the question. I think it's a very important point of view. Obviously, we only assess the treatment, but the diagnostic of the TMD is also very important. In all of the articles that we assessed, the diagnostic criteria for the TMD was used. So basically, that's an internationally accepted guideline for treating the TMD. And also, in some cases, there were some MRI and also CT imaging as well, which were involved for the diagnosis.
Yeah, thank you for that. Going on with that part, I think, of course, this is definitely also questions like what are the main problems of the patient? Like, is this the pain or is this the mouth opening? Brings me back to the treatment. Like, I know in this international standardization, they probably consider, but how much is this psychology part? Yeah, I mean, is this a part that needs to be treated?
Yes.
And is then their maximal mouth opening the treatment choice, or is this the pain relief? Can you comment on that?
Basically, the DCT-TMD has two axes, and the first one is mainly assessing like the physical problems of the patient, but the second axis is evaluating the psychosocial status of the patient. So basically, both of them are evaluated in the DCT-TMD.
Yes, and so you considered all the parts, but there can be still a kind of bias.
Yes.
Of the patient. Okay, and then coming to, yeah, because of course treatment is what we all want to do. When you talk about the physiotherapy at a certain moment in the study 1, who do you see doing that? And same for study 2, the injections. Who do you see doing that? And do we need people with a special training for that?
Yes, regarding the second meta-analysis where the arthrocentesis was conducted in Hungary, only maxillofacial surgeries are able to perform this procedure. Dentists cannot, as far as I know. And regarding the first one, I think that manual therapists should be involved in this field. And also the home exercises are very important, but in this case, the patient's compliance is crucial.
Very nice presentations. Maybe I can start with a comment. So, since your first meta-analysis concluded that bite plate is not efficient in treating myalgia, it brings us to the point that occlusion is not related to myalgia. Am I right? Yeah. So then TMD patients rarely have only one TMD diagnosis. If they have myalgia and limited opening, maybe limited opening is also not related to myalgia, but to the disc displacement without reduction.
Yes.
So my concern is also about the heterogeneity of the population that were included. Some of the myalgia patients probably were related to the night bruxism. do you think that in those subgroup of myalgia patients, occlusal splint could be beneficial or not? And if it is a question, would it be a good approach to make subdivision or sub-analysis of those chronic myalgia patients, not the acute myalgia patients? Acute is something that could be resolved by itself, but to chronic myalgia patients.
Yes, in our first meta-analysis, unfortunately, we could not do a subgroup analysis based on the population. It was only 7 articles that were included, and our aim was to just compare the treatment possibilities, but unfortunately we could not make a subgroup. But also I conducted another systematic review which was not yet published, and in this case the bruxism patients were there as the population, so we still haven't got the results of them.
Mm-hmm. And what would you consider as a short-term effect, and what would you consider it as a long-term effect? Do you expect after some short-term effect, which is good, to have some relapse, and why? Or you don't expect to have a relapse in patients with chronic myalgia of the masticatory muscles?
I think it's up to the treatment. Like, for example, for those patients who we are making splint occlusal splints, like Michigan splints, it's advised to use the splints every night. And basically, if the patient is not willing to wear the splint, obviously the treatment won't be successful. But normally, we always call back the patients for control in every 3 months, and then we are re-evaluating all the physical parameters of the patients. Mm-hmm. But unfortunately, in the first one, we could not conclude long-term results, so maybe randomized control trials of this topic would be interesting.
But you said splint is not important for them, so that doesn't bring additional benefit. So if the patient is treated with home exercises, wet, hot packages, cognitive behavioral therapy or something like that, do you expect in the short term that after a month there would be some improvement, and then do you expect after 2 months to have some relapse or some additional improvement with chronic myalgia?
I think there might be a relapse after like 1 month or 2 months of the treatment.
Why? Good point. Why?
Because maybe like additional treatments should be involved, like not only manual therapy but other treatments of the field, and because of the muscles can really get used to that treatment.
Mm-hmm. Or the compliance.
Yes.
The patient is happy that something has improved and he stopped practicing massages, and then we have some relapse, and then he realized that he needs some reinforcement by our side, and then there will be additional improvement. Thank you.
Thank you.
Thank you for your excellent presentations. And so it's not my specialty actually, but in the first meta-analysis you mentioned something about mathematical significance and clinical significance. Mathematical significance, it's clear, so it's a magic value of p less than 0.05, but what is threshold for clinical significance?
So, thank you so much for the question. I think the maximum mouse opening for men and women are of course different, but we are saying that like 45 and 50 millimeters for men are good, and for women it's like 40 to 45. So basically on this scale, if like a 5 millimeters change was there, I think it's considered clinically prominent and significant. And also when we are just checking the visual analog scale, it's a scale from 0 to 10, and 2 unit of decrease is, I think, considered as clinically significant, but yes, it's highly subjective.
Thank you. I would like to make a congrats for your nice presentation. You know, this topic is my soft spot of my heart, you know, and there are some small comments. What is the main role of the physiotherapy after the injection therapy? Which materials needs more focused, more dedicated, skillful physiotherapy, or maybe the PRP, or maybe the other materials needs more strict physiotherapy at the post-op period?
Thank you so much for the question. I think in all cases it's important, but like we are using PRP in most cases when there is a very big decrease in the structure of the TMG, so I would rather say with the saline and PRP combination.
Thank you so much.
Going on with that, I had also some question for this study number 2, because these injections, what intrigued me, when you look to the results, different combinations have, of course, a different outcome, but saline alone is also already doing something. And I just wonder if you can comment on that, but also comment on the fact if you looked to other joints in the body, if they use also this kind of saline PRP combinations. Did you look to that? Did you look in the orthopedic literature?
Yes, thank you so much. Actually, I've looked in the literature, and it's been a very well used procedure in knee surgery and also in the spinal surgeries as well. And what was the first part of the question?
The first part was, yes, could you comment? Maybe I can rephrase that question because you answered already the second part. I can rephrase the first part as saying, like, what would be now the pathophysiology behind adding to saline this PRP?
Normally we are using saline. We can use in all cases. Normally we use like 100 milliliters, and its mechanism is to flush out the inflammatory mediators of the joint.
Yeah, and the PRP is helping more in that than steroids, or?
Yes, because it can induce production of the platelet or the cells.
Yeah, and then something that the orthopedics or the neuroorthopedics would ask as well: how many times can you repeat it? Because it reflects like how many times if there is a relapse of the problems which he discussed with you, how many times could you repeat the injection with saline and PRP?
It's up to the patient's complexity, but normally in every 6 or 9 weeks, these are done again.
Okay, so eternal, yeah.
Yes, but we hope that once the patient is totally healed, so.
Okay, good.
So we really like the network analysis, and we typically interested in there is any discrepancy between the direct and the indirect comparison. So have you observed something like that, or no?
That's a very good question. I don't think so.
No problem. Okay, and the one additional comment that you... So first, I really like that you talked about clinical significance. You will say relevance. I really liked it. And in the first project, you talked about the heterogeneity based on two articles. That's what I have doubt that it has a meaning.
Yes, the first one was the Kucha one, where the patients could take additional non-steroid anti-inflammatory drugs, and as we were assessing the pain perception, it could highly modify the results. And the other one was the Katyayan article, where the randomization of the patients were not correct. That's why we excluded this article from the analysis.
Thank you.
Thank you.
Since Oleg actually raised up this question about what is significant and what is not, so this is a difficult thing, and this is not like my molecular kind of physiology research when I would like to see whether pharmacological agents does change in calcium signaling or whatever. So the point is that we have lots of discussions inside too, as you touched and actually Donnie also touched. So as we see now, as the studies are quite heterogeneous, and then there are tendencies which are not significant statistically, but we thought that that is important to highlight, that there is a change. And maybe we should use the term relevant. So that seems to be important, and that should be followed up. I mean, these meta-analyses are not at the end of the absolute evidence on a certain issue. But more importantly, I mean, we see some changes which seem to be very important, because in a certain scale, I mean, if that is really true, then what we see is that this is a, I mean, you can also come to this, of course, because this is a scientific discussion. And this is really a big question, actually, on science, that how to approach this. And then we try to, I mean, but we had discussions with the statisticians who are more, I mean, strict on these things too. So this is going on. But so maybe if we use the word relevant, is more appropriate than to use the word significant, although we mean on the same thing. And there must be there, but more studies are needed. I mean, most of our meta-analysis actually initiate further studies. Maybe you do that too. I mean, for clinical research, building up registries, building clinical trials, because we identify lots of, I would say, that unanswered questions, which we don't have the final truths. But these are actually very important, because otherwise, if you don't put together the present knowledge, I mean, you just don't have the direction. And this is what I think Kata studies also do. I mean, they just get the right direction, if I'm right.
Yes, thank you.
Thank you very much. Any more questions from the audience? I'm looking at that side. The other side, please. It is a very, very interesting topic, so I'm certain that some question will raise.
Can I ask one more thing? If we are here. Because, anyway, this is clinical science. I mean, what your findings, I mean, we understand that, and we do have a center, actually, at the maxillofacial surgery when they do interventions. So not, I mean, but how does it affect actually your work or the work of the clinics, what you figured out? Does it really have any effects on that, or your own work actually as a clinician?
Actually, at the Department of Prosthodontic, we have a specialist who is a manual therapist, and she works at the clinic. And if we have some very complex cases, we always ask for her help. But if like a very complex case which cannot be treated with first-line treatments, then we have a contact with the maxillofacial surgery department, and they treat these complex cases there.
Thank you. So until the audience is reconsidering, any questions? Just a short one from my behalf, of course in my specialty. In both study groups you just mentioned in your work, was there any information about orthodontic diagnosis or anomaly, or maybe previous even orthodontic treatment?
Yes, that would be a very interesting part, but unfortunately it was not mentioned.
No information. Thank you. So I'm asking the audience again for the last time. Then the committee, please. So if there are no further questions, then thank you very much.
Thank you.
For the candidate. Dear candidate, the committee, distinguished audience, we have made our final decision. So the point which was scored were 23 out of 25. That means an average of 4.6. That means the qualification of the degree is summa cum laude. So your defense was very, very successful. We congratulate.